I hope you had a tea break, and thanks for coming back. And we will be starting our panel discussion very soon. And the discussion, the topic for our discussion is you know is mainly, should India move from volume to value, and how and why? And that's the discussion that we will have. The discussion, will be chaired by Dr. Prashant Garg, and moderated by Dr. Anindya Chakrabarti. So let me introduce Anindya. Anindya is an associate professor in the economics area at IIM Ahmedabad. He received his PhD from Boston University in 2015. He has published in multiple peer-reviewed scientific journals. He's currently, his main research interest areas are in the economic and financial networks, business cycles, empirical industrial organizations, and complex systems. He's currently serving as a co-chairman of the Bridge Disa Center for Data Science and AI, and he's currently the UTI chair professor in macroeconomics at IIM Ahmedabad. He has earlier served as a co-chair of EPGD program in Advanced Business Analytics at IIM Ahmedabad. I request Anindya to moderate this session, and welcome on the dais, please. Anindya will introduce the chair and all the panel members, our esteemed panel members, for this panel discussion. Over to you, Anindya.
Thanks, Amir. So this is going to be a session with the topic Health Economics to Accelerate Policy Shaping, LEAP workshop. And my name is Anindya Chakrabarti, and I will be moderating the session. So first of all, I'd like to thank Dr. Raja to invite me here, and it's a great pleasure to be back here. Let me set up a bit of a context from the point of view of economists, and especially a macroeconomist, that too, to think about how technological evolution and regulations, they play a major role in terms of shaping policies, especially in the context of health economics. So the first thing is that is something that I would like to point out is, why do we have health economics per se? It's one particular type of market. It's one particular set of participants, those who are there. But that way there is a video game industry as well. So why don't we have a video game economics? So one of the key distinctions as an economist, the way we think of exactly why do we even have this, concept or different way of studying this kind of markets, is fundamentally goes back to one very particular idea, whether a market can cater, a market can sort of clear itself on its own, or does it require guidance from the policymakers or not? And what differentiates healthcare from other, many other markets, it has a similarity with education in this respect. There is something called informational asymmetry. And the informational asymmetry being, so if you go to purchase, let's say, some kind of product on Amazon, you have a pretty good sense of what the product is, what does it do, and there is a way to return it. The problem with healthcare is that none of them are possible. So as regular consumers of healthcare service, I have absolutely no clue. Whatever the physicians are telling me that, these are the diseases that you have, I really have to accept that. I cannot second guess on the basis of that. Technically speaking, I can, but then it becomes like a problem, right? So the market by itself does not clear. So because of this informational problem, that is where the role of the state is or some kind of regulator is very, very eminent and evident in the context of healthcare. And that is where the question of policy shaping comes in, right? Because in that case, whatever the policies that are taken, that sort of determines the path following which it's like a matching process where the physicians will be matched with respect to the, the patients, right? What are the rules of that matching, whether that match generates the maximum value possible or not, etc., etc. Those questions need to be understood in the perspective of that matching. This is where the market by itself cannot clear the market, cannot really match just providers, the supply side, and the consumers, the demand side, and expect that the market will clear by itself. The other obvious reason to think about is the pricing implication, right? If you leave everything to market pricing, then there is a problem. You have seen the surge pricing, let's say in Uber. It's actually not, it's not like a conspiracy theory that Uber goes after when the surge pricing leads to you going from here to 1 kilometer away, will charge you $500. That's not a conspiracy. What is really happening is that right at that time, there is an excess demand in the market. Increase the price, market clears. That's how markets work. But obviously, that's not feasible or even ethically acceptable for healthcare products. So you cannot really rely on market mechanism either to clear the market in terms of quantity or in terms of setting up the prices. That doesn't mean the market has no role at all, but it's in conjunction with respect to the policy, the regulators who will regulate the market, set up the policies. So this is where one major component of why this informational asymmetry requires policymakers to get in, set the stage. Now, the second thing is something, this is where I would like to, borrow from one of the earlier speakers. I think it was Dr. Murthy was talking about these key informants and how do you diffuse informations, let's say in different villages, in different locations, etc. This is something that we are going to spend some time on to think about how to spread information. This was touched upon by all of the previous speakers, that one very big important role is that it's not only the availability of technology, but people have to know that the technology is available. So this knowledge is often missing. So then the crucial question is, how do you diffuse that information? And this has been a major question for a very, very long time. Simply the technology being there does not make people appreciate or even know that there is this, life-saving technology that is accessible. So how do you bridge that gap? So one possibility is to bombard people with information. That's very costly. The other possibility is then to figure out what are the key points of injection in the social network or in the market network to figure out that who are the most likely person that if you train them, that would lead to the highest amount of dispersion of that piece of information. And these days, economists are constructing and running randomized control trials in order to find out who is the most likely person that if you feed an information will lead to most of the information diffusion within well quantified, let's say, regional setup. It could be a village, it could be a small locality, etc., etc. These are the things that nowadays we understand pretty well. As long as you understand the social network, you can very easily see or identify who are the most likely sort of information diffusers. So then accordingly, that becomes part of, obviously, the most important implication of that is public health. The other thing that I would like to point out before we get into the specific topic here is, even when this kind of information is diffused, it's not clear that people act with respect to it. So for example, here is one example that I would like to bring up. There is a work that I did with one of my PIs, who is one of my collaborators, who was also a PI here, Professor Chirantan Chatterjee, who will be a part of this panel going forward. So what we were trying to see is that a new way of nudge that is created. It's not really a nudge also. It's really information provision by calling up people. So one of the biggest examples of that was that during COVID time, people were like, every phone will have a message recording at the beginning of it, like every phone call. What is the proof that worked? So later on, I was very curious about it. I myself do not quite study this, microeconomic structures, but I was very curious about this information provision. So I asked people that, now that you have made the call, can you tell me what was the message? Almost no one could answer. Yeah, there was something, recorded about COVID. And so most of the time, people don't even recognize that whatever is being relayed to them, if it is at random, they do not even recognize. People have finite amount of attention that they can give to certain informations. So even if information provision is there, people may not actually take that up, may not consume that. Right? So therefore, then one has to be really cautious, really careful about which method of nudge again works. And that is where again economics plays a huge role in terms of developing and seeing a whole types of treatments that you would think that immediately informs people don't work. So then what we see is that, one, there is an informational asymmetry problem. Two, even if information is there, people may not quite react to it. And three, correspondingly, eventually there could be a market failure because of that. Market failure is the technical jargon in economics where we say that the market by itself is not being able to clear, right, in terms of both price and quantity. So here the topic that we are going to talk about is, should India move from volume to value and why? The other learning from economics is that certain types of market structures emerge because there is a path dependence, because there is a history. It doesn't emerge all of a sudden in a vacuum. So given that here the premise is that we have a volume based system, it was not done in a vacuum. There was a very good reason as to why it really solved certain problems at certain points of time. So the question is not really in an abstract setup whether it's volume or value, because the trade-off may not exist at that level. The question could more well be that in an evolving market scenario, whether it makes sense for the market structure now to change from volume to value. Now, what are some of the broad trade-offs that one can sort of think of? The key point, as far as I can understand, and then later on, we will gather more, ideas and insights around it from the practitioners and the, academic people and policymakers. One of the key point is that and this is something that economists really believe, or at least I really believe as an economist, a certain structure emerges because it's incentive compatible for the market participants at that point of time. In theory, everyone can say that, yeah, another system is good. So if it is good, then why doesn't the economy or the market or the system doesn't immediately change? A big reason is that the current, or that is why status quo emerges, it's incentive compatible. Now, what is the incentive? As far as I understand, the incentive is to identify, it's like a binary thing, identify, expansion of market. So it's called the extensive margin argument, that if we can, increase the market size by getting in, let's say newer patients, then that is the success. That is the volume based idea. The value based idea is the kind of complementary to it, is that it has to be in the intensive margin for the existing market, whether the value addition is more or not. That is not something that is generically, adequately priced, the value addition for a given patient, because the outcome we often tend to think in terms of a binary, whether the disease was cured or not in terms of like how much, to what extent it was relieved. And the pricing does not differentiate based on whether the outcome was very good, moderately good, somewhat good, not good at all. Right? Pricing variation cannot be done in this case. So there are these many different, kind of economic problems. One, you cannot, segregate prices. So it's at some level, one can easily think of like going to a, value-based care. The healthcare becomes lean and trim, very efficient. So the extensive margin argument for the, for a while, let's say that's put on a hold. In the intensive margin, higher value addition to the patient, assuming that both the patient and the doctor agrees that this is a value addition, then accordingly that is priced. That cannot be done. Pricing cannot be changed. The price has to be still the same. Because again, why prices cannot be changed? Because most of the consumers do not understand that the value addition is high. It will be the providers who will understand that no, the gain is actually more than the other case. But it will be almost impossible to convince the consumer that no, you have gained more than another case. So pricing differential cannot be done. So in that case, the problem is like a really constrained optimization. You have to come up with single price, cater to a large market, but then at the same time, you have to ensure that the values, distributions are there. So this is like a super complex problem where more and more different insights are important, and most notably from practitioners, because I think as I don't know if you have watched the movie Oppenheimer, it's actually comes up with a brilliant, idea. Theory can take you only so far. So, being economists, sitting in ivory towers, there are some theoretical, kind of challenges or theoretical ideas that we can identify. The best way to do it, to go forward, is to really think about what the, practitioners think, what do the, policymakers see as the, major challenges. So that's where we have invited, along with very generous help from Samir, and the IHOPE organization, very solid list of, panelists with illustrious careers and tremendously experienced. So we have Dr. Krishna Reddy, Dr. Rajan Narayanan, Professor Chirantan Chatterjee, and Dr. Amit Dunn, who have been formally invited for this session, but I think we will need to also incorporate some other insights and discussions from other scientists who are present in the room. So let me just quickly introduce. First, we will start with Dr. Prashant Garg. He is the executive chair of LV Prasad Eye Institute, succeeding the founder chairman Dr. Gullapalli and Rao. He is an internationally renowned leader in corneal infections, antimicrobial resistance, and eye banking, a recipient of numerous prestigious awards nationally and internationally. He's on the boards of several international organizations, societies, scientific journals, and is in the room today. And we are very glad to have you. We know how busy you are, and we are really grateful that you gave us time to be here and set up the context from the physician side. So we will start the panel discussion on thinking about health economics to accelerate policy shaping, in particular from volume to value, with Dr. Prashant Garg. So welcome you.
Good afternoon, everyone. First of all, on behalf of LV Prasad Eye Institute, I'd like to welcome you to our campus. A confession that I am novice to this whole field of health economics and volume to value based care. But I think this was a good opportunity for me when Raja said that you will be chairing this session to pull out books on volume versus value based healthcare system and get educated on that aspect. I like to put before you the fact that today we are living in a society where close to 1 billion population has no access to eye care. And this 1 billion comprises of almost 1/3 of the world population. Now, in this context, when on one hand, people have little or no access to healthcare, can we completely ignore volume-based healthcare is a question that came first in my mind. I still very clearly remember when I was doing my residency in 1990, all residents had to go to eye camps. There were large, big, white mobile vans, and we all had to spend some time in the eye camps where we were doing large volumes of cataract surgery. And as Dr. Murthy said, that while at that point of time, the success of this intervention was measured by the number of cataract surgeries performed under each of those mobile units, subsequent analysis clearly showed that most of these patients who we intended to pull out of the blindness were still blind. So the value addition was marginal. I experienced that when we started our eye banking in 1989. Huge waiting list of corneal transplant recipients, but there was no availability of corneal tissue. As and when we were getting corneal tissues, yes, we were doing some preliminary evaluation of the tissues. We used those tissues. But we realized that many of these patients are at risk of developing corneal infections as a post-operative or primary graft failure, and therefore they still remained in the blindness registry. So question is that if you are living in a society, care resources are sparse, where health care is not available, should you be thinking about making a move from volume-based healthcare to value-based healthcare? Or should there be a marriage between volume and value so that you constantly keep focusing around the number of people that you are bringing into the ambit of healthcare, but also ensuring that all of them achieve a reasonable good outcome? That is the value addition. Now, these questions or that dilemma between volume and value-based care become even more complex if you start building health economics into it. For governments which are spending very meager amount of their GDP into healthcare, if we do not bring out value out of every rupee or every dollar that we spend on, we probably will be creating a monster before us. And the third aspect is where the change in the mindset and the way healthcare is changing is crucial. Today, the healthcare is always looked as a profit-making entity. And what again Dr. Murthy pointed out, 3 C's, which are becoming a worry. With influx of lot of foreign direct investment, with many of the companies having interest in equity, the whole landscape of the healthcare is changing. And we have to take that into account if we have to ensure healthcare to the person living in the remotest rural area or belong to the disadvantaged community. With that, I'm eager to participate in this debate and learn from all of you. I don't know how much will I be able to contribute, but I am very open to learn from this discussion. Thank you very much.
So now we have a panel of experts. I will quickly introduce them. We are very happy to have Dr. Krishna Reddy. He is the president of Access Health Asia. He is a board certified cardiologist with a long distinguished career, marked by his leadership of the Care Hospital Group, which he helped to create as well. And this hospital group is now recognized as the most advanced complete cardiac care center in the country. The hospitals have become models for patient satisfaction and innovation. Dr. Reddy earned his MD from the Postgraduate Institute of Medical Education and Research, Chandigarh. He was also a fellow in cardiology leading to DM from the GB Pant Hospital, Delhi University, New Delhi, and an assistant professor of cardiology at Nizam's Institute of the Medical Sciences, Hyderabad. We have, after that, Dr. Raja Narayanan, who is the Network Director of Human Resources and Anant Bajaj Retina Institute and Director of Suven Clinical Research Center. He is the PI and co-founder of IHOPE, for which I guess we are all here. So thanks to him. It's funded by DBT, Government of India and Wellcome Trust UK. It's a collaborative project of LVPI, IIM Ahmedabad and Public Health Foundation of India. He is also an adjunct professor of ophthalmology at the University of Rochester, New York. We have Professor Chirantan Chatterjee. He is an applied economist working in the economics of technological change, pharmaceutical markets, and global health. He is currently a professor of economics of innovation and global health at SPRU in University of Sussex Business School in UK, and a visiting fellow at Hoover Institution, Stanford, in the US. At USussex, he is also the PhD program convener and co-director of policy training and executive education. His research interests are in economics of innovation, applied microeconomics, empirical IO, industrial organization, and global health. Dr. Amit Dung is our fourth panelist. He did his MBBS and MD pharmacology as a gold medalist from Goa Medical College. And he was the recipient of Baba Saheb Ambedkar Award for being the university topper. He started off his career as an entrepreneur and has been working in the pharma sector for almost 13 years now. He is the founder and CEO of Marksman Healthcare, a global HEOR and medical writing consulting firm. He is the course director at Marksman Academy of Health Sciences, which has launched an online certification program in fundamentals of health economics and outcomes research. He served as the president of ISPOR Mumbai chapter for 6 consecutive years, and he has over 100 peer-reviewed publications and posters to his credit in various national and international journals. So the way we envisaged holding this session is that there are some kind of key questions that we would like to run by the panelists, and we would hope that based on their answers we can elaborate further following up the discussion. So first I would like to invite Dr. Krishna Reddy. Please. And based on his enormous amount of experience that he has, one question that we would like to pull up to set the ball rolling is this is something that has been pointed out earlier by some of the speakers, that the share of out-of-pocket expenditure is really pretty high. Yeah, please. So then maybe because so is Chirantan there? I'm not very sure. Chirantan joined.
We can project him on the screen.
Yeah, okay, so then let's please. And
I'm there.
Oh, okay. So I guess Jonathan is there. So the first question that we would like to start with is based on our understanding in terms of this high out-of-pocket expenditure, which can be generally pretty detrimental. So one kind of glimmer of hope that we are seeing is that as per a recent World Bank report, the share of out-of-pocket expenditure has declined from around 62% to 47%. So which is a very welcome development. And based on that, what are the benefits that we can expect for patients in India in the near future? What kind of data do you think we can gather in the Indian context? And more broadly, how this patient's income and wealth correlating with the patient health that can be taken up as a matter of discussion into this debate about whether it should be volume-based service or value-based service. So we would like to hear from you.
Yeah. Thanks, I think. I'll start with this out-of-pocket expenditure that we mentioned. India, of course, is one of the highest out-of-pocket expenditure, and recently there has been a reduction. But whenever we talk of the out-of-pocket expenditure as a financial hardship of people in seeking healthcare, so the higher it is, that means the hardship is more. That is the indicator used by economists across the world in measuring what is the financial hardship of the people. But it's a poor indicator. One is when you say out-of-pocket expenditure, we're assuming that they are accessing healthcare. Suppose they don't access healthcare, they don't spend. So we don't know. So that is one. The second is, again, how many are actually foregoing healthcare? For example, if somebody has a heart failure, if you have to follow the guideline-based therapy, you have to give 5 drugs, proven drugs. You may have to give a defibrillator. But when we actually counsel the patients based on what they can afford, what they are financially protected, I may not actually inform that you require a defibrillator. Because if I inform that you require a defibrillator, the family, they feel guilty that they have to take care of the family member. They sell their properties. And they have that for that incremental extended life of another 6 months. This is the real life example of why this out-of-pocket expenditure is a poor indicator of financial hardship in the Indian context. Thirdly, in the Indian context, we again don't measure whether this 40% out-of-pocket expenditure is causing the financial hardship. As a family, to me, financial hardship is if I am stopping my child from going to school, if I'm reducing one meal in the house, or even the basic housing I don't have, I have to stay outside, or I have to sell my assets, or I have to borrow money at a high interest rate, and I get into the poverty cycle. So we are not measuring those indicators. Typically, in the universal health coverage mandate of SDG, by 2030, India is supposed to have universal health coverage. That means 80% of the people, should not be spending from out of pocket, maybe a load of 20% of the people. But given this mandate, we are moving towards that. All the major reforms that are there, health and wellness clinics and PMJ, they're in the direction of moving toward the USC by 2030. But again, as I said, we have to really look at this hardship definition of this out-of-pocket expenditure. Unlike in the West, when we use two words, actually, what is the impoverishing health expenditure? That is, if it exceeds 10% of your income. Then what is catastrophic health expenditure? That is, if it exceeds 30% of your income. But in India, we don't have income data. We have only expense data. The family surveys which you use, by NHFS family survey we use, that is the expense data. So in the expense data, if a family, we did a population survey, even the lowest quintile, socioeconomic lowest quintile, when we inquired, they are saving 20% of their income. Because that is an adaptive behavior in the Indian context for the future resilience. They may be not eating the full meal today, but they are preparing themselves for the worst case scenario. Then again, we asked how many of you actually sold your property for seeking healthcare. Only 1%. This is a given cohort. It may not be representative of all the cohorts. So we don't have, in Indian context, we are a saving country. Unlike the West, which is a credit card, we are a debit card. We don't take loans. We try to save money for the future. So there is a case actually from an economics point of view that we need to rethink whether we have to go with this indicator of out-of-pocket expenditure. Then the other point which you mentioned, see, health systems are evolving. The first and foremost is, do you have access to the doctor, drugs, and the diagnosis? That is the first premise. You have to complete it first. Then it comes the affordability. Are you able to afford to access this needed care? Then the third thing comes is the quality. Are you assured of a basic quality? Is it safe? Is it effective? Then when all these three things are achieved, at what cost you are able to provide these health needs of the people? That means you are providing all people without differentiation, equal opportunity to access, the basic quality of care. That is what universal health coverage. But the countries which are going through this evolution of health systems, like the US classic example, when the 20% of GDP goes to the health expenditure, then they're looking at, is it sustainable? See, Michael Porter's, the whole conceptual equation of value-based care, quality by cost, came into light because the US is becoming unsustainable. So if you look at the Thailand model, they spend same as India, 3.5% of GDP. And when you look at the health outcomes parameters, normally we say health status means what is the longevity, what is the disease burden, what is the premature mortality. Right? So these parameters, they are equal to US. So that means that at a national level, Thailand is the best value-based care that they are providing. So you have to study how they are able to achieve it, because they invest into primary health care, they invest into health promotion. And they invested into that everybody should be accessible for basic essential care. So we have the risk of actually extrapolating that economic approach to medicine. Recently, the World Bank thinking has changed. Pre-COVID, the economists looked at economic justification of health expenditure. They looked at it as an expense. But now World Bank says health is a goal, not an expense. From whatever it is, you be efficient. You be efficient in terms of managing the volumes at a least cost. So the input to output, you have to be efficient. I don't agree volume to value. In fact, the quality definition, dimensions of the quality is you have to be efficient, you have to be effective. Efficiency is input to output, efficiency is input to outcome. So you need to measure. In fact, there are measurements of efficiency, there are measurements of outcome. So answering your question, I mean, what is the direction is, India is on the direction of at least moving towards the US. And also it is focusing on access to care by health and wellness clinics, 160,000 across the villages. So in fact, India is the country where it is investing public money 52% in primary health care, 30% in secondary healthcare, only 6.4% in tertiary healthcare. So that is the right model in terms of creating value for the tax money that government is spending. And it should further strengthen that area. While from a patient perspective, I mean, from a payer perspective, I'm paying for you, I look at priority setting, I look at cost effectiveness, I look at economic value. But if I'm paying, right, from a family perspective for me, every 1 day extra is important. So any economic model, apart from you covering whatever you want to cover, don't define that this should not come into the guideline because economic value does not make sense. Because for a patient, some patient wants, even if it is a 1% chance, I want to spend money on it. So you need to create an innovative financing models. Innovative financing model to still make it possible to access innovations, advanced life-saving innovations, instead of borrowing at 24% interest rate from unscrupulous unsecured loans. With the fintech solutions, why can't you actually make it easily available as a consumer financing? I mean, these are the themes which we worked as a part of Access Health, fintech for health, innovative financing methods, because no time, because you have only finite funds. You cannot meet the infinite health needs of the people, and they are dynamically changing. You can't define what is essential for you. I need to define whether it's needed for me or not needed. So this is the dialogue that I think it's still evolving. I would say from an Indian perspective, we need to question some of the existing thought processes that come from the top, the global health perspective.
So based on your experience, these instances of catastrophic expenditure, healthcare expenditure, one way to mitigate that, do I understand it correctly that you're saying that by expanding the health coverage to begin with at the grassroots level, it's much more easier solution than actually catering to the eventual catastrophic health?
No, it has to be both. I mean, see, if you look at coverage system also, we are covering initially only the emergencies. Next, you are covering all hospitalization. Hospitalization is a major health care, right? Then you are thinking of now covering ambulatory care, the day care. Then there is a demand for covering the outpatient care. Then there is a demand for covering the preventive care. And there is a demand for promotive care. So this is a journey actually. So first and foremost, you have to safeguard the catastrophic expense. The next, impoverishing expense for hospitalization. Okay. Then the ideal state is that you are able to access without any financial hardship. This is the journey. I don't think either or.
I'd like to bring in Dr. Rajananan into the...
It may be worthwhile to bring in others.
Okay, all right. So then I guess we can go to Chirantan. Chirantan, you're there?
I am there, but the host needs to switch on the video.
To start the question.
So let me ask the
Can
question.
you see me now?
Not yet, but I'm sure we are going to see you very soon.
Okay, go ahead, Anindya. Please start your question.
Let's have questions to you. One is that there are two dimensions on which we would like to hear some of your thoughts. The first one is if this, what are some of the key learnings that we can adopt about this value-based care from some of the other settings that other, let's say, developed countries have already seen? Do we have a lot of learning from them, or should we start from the scratch and figuring it out kind of adaptively, suiting the local needs? So there are arguments, I suppose, in both sides. So what is your thought around that? And the second thing is, based on your work that you have done a lot, I know, over the last 7 to 8 years. Whenever there are these regulatory interventions, often they come in the form of a price control policy. So what are the unintended consequences that come along with such price controls? Let's say we think of both the questions in the Indian context. So I'd like to first elaborate on these questions, and then we can take the discussion forward.
Sure, you should be able to see me now at the back in the screen also. Okay, so first of all, thank you. I am sorry I could not be there physically, but it's fun again to see the IHOPE conference happening for the third time. I think what Kanchana was talking about, the 2447 Vision Amrit Kal. When I listen to the interlude music, I feel like we are really setting the tone for Rag Amrit Kal, and I congratulate the organizers for that. Coming to the question on value-based payment, it has a history of about 60 odd years now. The first discussions on HTA and value-based payments started in 1965. Some of us already are aware of that. There are some standards here that, let's say, NICE and Sweden and Australia have set up, which I think definitely needs a meta-analysis in some sense. I have been hearing about HTA a lot also in China. This summer, I was in China giving a keynote at Peking University and in Nankai University. And one of the important issues there was the diffusion of robotic surgery, and Intuitive was there, and the country head of Intuitive was trying to convince the local Chinese makers that their intervention is working better than other interventions. Now, going back to this point about how to set up data, and the word that is being tossed here is evidence-based medicine. My big worry here is that it better be evidence-based medicine. It should not be medicine-based evidence. And when I talk about medicine-based evidence, I want to refer to the real rage right now in the pharmaceutical world, which is of anti-obesity medications and Wegovy and Novo Nordisk. And what has Novo Nordisk gone through with NICE is an illustrative case of how evidence-based medicine could potentially become medicine-based evidence. So in March, there was a Guardian investigation talking about lack of full disclosure of Novo Nordisk to patient support groups in the UK. And then Novo Nordisk was not allowed to participate in the British Pharmaceutical Industry Association because there were inadequate disclosures of how they were paying patient support groups and how evidence potentially was being distorted in the way anti-obesity medications were being diffused here in the UK. It's an illustrative example going back to what my China experience is also telling me in the robotic surgery context as well, that when we talk about evidence-based medicine, it better be evidence-based medicine. We need to appreciate what are the outcomes. In our OCTA project that Anindya, Savan and me are doing, there are certain types of outcomes we are doing with the electronic medical records data set, but those may not be the only outcomes we want to look at. We want to probably look at long-term outcomes versus short-term outcomes. So there are some challenging questions here from the history of HTA and value-based care we can borrow from Sweden and NICE and Australia. So it's important to do a meta-analysis and then see where are the boundary conditions and limitations they have dealt with, and where are the new things that they are doing and the things that they may not be doing wrong, right. And then come up to a policy recommendation on how HTA should be adopted in the context of universal healthcare in India. And I think IHOPE can set a precedence there in creating that kind of a meta-analysis based recommendation on what should be the pathway for value-based healthcare and HTA in India. On the question of price regulation, it is kind of related in the sense that Dr. Prashant said in the beginning that it's very difficult to let go of volume in a context like India, and absolutely affordability and access has to be taken care of. And the political incentives obviously are super sharp in the context of using prices as a low-hanging way to convince that the policymaker is doing something in healthcare. But we forget the fact, one, obviously around the dramatic level of ramping up we need to do in public health expenditure as a percentage of GDP, and two, the unintended consequences of price regulation, which standard economic textbook tells us in India through deadweight losses, and then there are classic examples of the unintended consequences. Two things that I have found in my research: one is that firms strategically behave, anticipating price regulation, moving away product markets to markets which are away from the market which will be regulated, having ex-ante information about the markets where price regulation will be incident on. The case study I'm talking here, which will be illustrative, but has happened in other drug market contexts, is Dolo 500, where the industry knew that it's coming and it shifted the equilibrium to Dolo 650. And we see evidence of this in research. And it's illustrative for price regulation in many other contexts like stents and other areas as well. And the others, beyond strategic behavior, price regulation can have a consequence in creating black markets, as we saw with Remdesivir during the pandemic era. When different states and government tried to cap the prices, it actually created a black market channel. So we have to be careful about how to think about price regulation, because the history of price regulation has not been so, I would say, in the ultimate patient welfare enhancing, and it has actually been value destroying. But I completely appreciate the fact that Dr. Prashant was saying, which is we are a country of still so many poor around us. What might be a way to diffuse value-based care innovations to the bottom of the pyramid is something where the 2047 agenda can actually set a precedence in. So those are my humble thoughts on HTA and price regulation. Thanks.
Thanks, Chirantan. So based on this, I would like to turn it to Dr. Dunn. So we are still in the domain of economics. So there is this concept of missing middle in the insurance context, where the idea is that the rich folks can potentially get their own private insurances. Maybe they're literally the lowest one because of government interventions. Maybe they will be under public insurance. What about the middle cohort? So how to cater to that? So based on your experiences, how do you see an affordable and sustainable insurance product catering to the missing middle? And do you think that the existing PMJI coverage can be increased to take care of that, or do you think there should be more complementary policies coming in to cater to the full income spectrum?
So yes, as you rightly said, there is definitely a segment in the society, we call it as a missing middle, which are not that much affluent that they can afford the insurance from their side. And as per the government definition of who can avail the Pradhan Mantri Yojana and PMJ schemes, they don't even qualify for that. So they are somewhere in the middle, and they need to bear the brunt of not getting the right insurance plan and the right access to different insurance schemes that the government provide. So when it comes to the perspective from the government side, so yes, the government is definitely thinking on those lines. There was a talk on the Ayushman Bharat 2.0, wherein they are planning to bring close to 500 million people under the Ayushman Bharat scheme that's there on the agenda. And if that happens, then almost 75 CR people in India would get into this whole Ayushman Bharat scheme. And the government is definitely trying to have a very comprehensive dialogues with different private insurance companies, so that they can help them out by catering to this large population, because eventually the volume is going to get increased, but they also need to be flexible when it comes to the insurance premium, because that is something which is a problem when it comes to the missing middle. So the dialogues are going on, and definitely this can be one such thing where it could be, say, a small premium needs to be given from the missing middle, and the rest is being taken care by the private insurance under the Ayushman Bharat scheme 2.0. So that is something they are thinking on. Then I also read about income based sliding scale fee. So as I mentioned, that missing middle is one such segment which neither goes into the category of where they can avail, and they don't have enough of the money where they can even pay for that much premium. But depending upon the kind of income status that they have, which of course will be a bit difficult, as one of the speakers mentioned, that we have an expense data, but we don't have as much the income data. But when it comes to the middle income, they're mostly salaried, so it might not be as much challenging to get the income data from this particular strata. And depending upon that data, if the government can come up with a joint plan with the private insurance companies to figure out that how the premium can be reduced and still they can avail the 5 lakh family floater for themselves. So that seems to be one of the very logical decision or a stand that the country might take to get close to 75 CR people under Ayushman Bharat 2.0, which would be actually very great.
To invite Dr. Garg to share some of your thoughts on a question. So I know that it's on the fly, but if you have some ideas on this whole concept of universal health coverage that is coming up in India. Do you see a scope for value-based care as part of this universal health coverage, or by definition it has to be really volume-based care, and that is what we should stick to, because it may be a question of survival rather than having, let's say, I'm misusing the word, but it's like a luxury to have, which is value-based. Can you share some thoughts on that?
I think very interesting question, and the counter question on that is what we mean by the value-based care. Isn't a universal health coverage itself is a value?
I guess goes back to Dr. Reddy's.
And I think this is probably the first thing that we have to assure, that the healthcare is available. It definitely comes with the cost, that at times the outcome when you expand the horizons may not be great. The healthcare is at least available. As a phase 2, you start working on the minimal standards, and we assure that anybody who is seeking healthcare get those outcomes. And then the phase 3 comes, where you start looking at the health economics and look at what is the cost of the healthcare and who is going to be providing that. So the whole equation of health. The India at present is at a very, very kind of a critical position, where the Ayushman Bharat scheme has come. Many state governments are funding healthcare. But I think what is missing is that most of these schemes are limited to tier 2 towns. And we have not made enough effort to popularize health. In the morning during the board meeting, we had a discussion that around Mudhol district, or the Nirmal district, Mudhol town, where we have the secondary center, we are currently undertaking a door-to-door survey of entire population. And the preliminary glance at that data very clearly suggests that if you are within 50-kilometer radius of the proportion of patients who are blind with cataract in both eyes is much, much less as compared to if you go beyond 50 kilometers. Clearly indicating that the lack of availability of healthcare keeps them away from health seeking. So, what will happen in the healthcare system as we will evolve, probably with our expanding reach with several initiatives the government is taking? I think then will be the time that we will have to shift and start focusing our attention on outcomes. One of the other value addition I like to, or value-based care I like to think, is that many times we say the outcomes are X. The question is that how are we measuring those outcomes? Are these outcomes from a limited pool of patients who have accessed healthcare into the kind of best expertise, or are these the outcomes that are universally represented? The other aspect that will come is that who is accessing? What is the minimum cutoff for accessing healthcare? In cataract surgery, we say that everybody who is undergoing cataract surgery should get 6/12 or better vision after cataract surgery. But if the cataract surgery is performed at even a better vision and they end up having 6/12 vision, what will you label that? They still fall into that they have achieved whatever target. So to summarize, I think we are at a very interesting crossroad where the whole thought process around volume-based healthcare system to value-based healthcare system is happening. But it will be that what value we assign. So at times even the volume can be a value, matter of putting that in perspective.
Here I'd like to turn to Dr. Narayanan. So you have a very interesting editorial in IHOPE Journal of Ophthalmology on national health transformation. So how do you see stitching this discussion that we have been having? That there can be questions of definition about this volume to value trade-off, and whatever the other countries have done in terms of that transformation. How do you see the Indian transformation taking place in terms of healthcare? What are the things that are now currently happening at the grassroots level, and what are the things that we should prepare for going forward? And what would be out of the broad path that you think the economy will take, kind of, while it will take?
Great question, but not an easy question to answer, I'm sure. But we have heard experts speak here. There's a lot of work going on. There is a lot of work, initiatives which the government has taken. That's a very, very positive. That's the most important steps are looking at value, how to provide value in the healthcare. And if you look at the white paper which was brought out by NHA last year, or public opinion also they had asked, we are bringing in value-based care, not just volume. So what is it that we are talking when we say value and volume? Are they dichotomous? Are they opposite of each other? Not at all. I mean, if you have increased volume and you say that means you will have low value care, that means India can never have high value care because of the high volumes. Is it that? No, that's not the case. And also the point that we are all aware that the spending in India is less in healthcare as percentage of GDP. But it's also not necessary that if you increase the spending, you are necessarily going to get high value care, or the outcomes are going to be better. Dr. Krishna Reddy pointed out about Thailand versus US, and even within US. We know the outcomes are not very great in US, but also within US, the state of Mississippi has so much of high expenditure, but ranks one of the lowest among all the states. A lot of it related to preventive care as well. But what we have to look at is where do we put the money appropriately? You have to increase spending, but it's not automatically going to translate into profit. We have discussed about defining the outputs. What is high value or good value? There's debate going on, but at least we know how to arrive at it. But I would say that overall we need to measure the outputs. That's a big area that we are lacking. Even if we define value or outcomes, there is hardly any data capture going on currently. And that's where I would say, yes, there is a lot of activity going on in terms of digital health. One is the electronic health record system, but there are many other digital data which can provide in terms of evidence. And that is, you asked, are we doing the right thing? We are talking the right thing. In LV Prasad Institute, we have done it long ago, the electronic medical records. And it's a gold platinum put together kind of data that we have as of today. But that needs to be scaled, that needs to be increased. And that's where other systems are also coming together, including NCT. Lupin is working along with them. That's an ecosystem, and it's not government driven. Government did not tell LV Prasad Institute or National Cancer. And we need to have, at some point, realize that we have to take accountability as an individual or society and not put everything on the government's lap. That you have to do, you are to blame. We are part of the government. And we have to develop systems. And that's where, even for part of the question you have not asked, but I can tell we have discussed about health financing models. One system which again we have a huge experience is the economic cross subsidy model. That's not talked of. We have talked about the vertical care or pyramidal system, but the untalked of system that we have here is the economic cross subsidy system. It's self-sustainable. Everybody gets care. We don't talk within LV Prasad Institute volume or value. We are not debating that. We are providing volume. We are providing value. We are measuring the outcome. We have the data. We have the real world evidence. What is that economic cross subsidy model? That in terms of clinical services, they are all the same. Whether you are the richest person owning a conglomerate or you are a poor, indolent person at home, it's the clinical care that we are providing. We may be doing that in a differential pricing for certain value-added services, which the individual perceives a different price that they can pay for that additional value. So it's like they get more services in terms of non-medical care. They pay a higher amount. We call them side savers or exclusive package. And that generates a surplus. And we use it to cross subsidize our poor patients. We are operationally self-sufficient. No government involved here. But this can be utilized as a model. I'm not saying it is complete magic for everything, but it's a powerful tool. It's an extremely valuable tool. Just I would like to give an example of an aircraft. You may fly business, first class or economy class. You have different price to pay for the ticket, but your destination, ultimate goal is the same, that you reach that particular destination or city from your city of origin. Your destination is, that means cure of blindness, or cure of cancer, cure of whatever. That's your destination. Each person in that aircraft is paying a different price for it. Their value perception is different. No government has told to do that. The pilot is the same, the aircraft is the same, right? So you should remember this also. Pilot is the same, the aircraft is the same, The value-added services are different, and there the passenger decides whether I should take this additional value add for this price. So that's a beautiful example, and I think some systems are exploring that. I think these are some of the points that I would like.
So thanks, Dr. Raja, for raising this point. So I have a question about the scalability and the associated cost with that. But I would like to go to Dr. Reddy once. And so here the suggestion was to think how intra-organizational cross-subsidy can be a useful tool for catering to the poor borders. But in general, what we have seen is that people are generally speaking, sort of the word that we use in the business school, that there is a financial illiteracy. So they do not quite know what are the options available, let's say, for different kinds of financing options, health financing and so on, which eventually turns to catastrophic, healthcare expenditure as well. So in your, based on your experience and what I was looking at is that this expanding kind of scope of the work that, you're doing, getting into newer geographical locations. Do you think that that also inculcates a sense into people that, well, so along with this healthcare provision, I should also take care of myself utilizing some of the financing options as well? Or is it still like a separate domain that people simply see this expansion as more like a healthcare cover, a healthcare, like provisioning of physical healthcare facilities? They do not think in terms of the financing option along with that.
Yeah, the two things are there from a patient perspective. They only look at from what they have coverage. In fact, we support UP government in implementing PMG. We are driving the value-based care there. The first task was actually people were not aware that they have patient. You first covered that. Once they were aware, they were not aware which hospital to go to. So there was no uptake. In fact, there was a lot of crisis. There was no utilization. Hardly 0.2% of people. Nominally, you have about 3% people utilizing the hospital, but they were using only 0.3%. That means they were not aware where to go, and they were not aware that they have to go early. So this is suppose from a patient perspective, what is your priority? When you have a chest pain, you want to see something. Until you have a chest pain, you don't care. So when they have a chest pain and when they feel that they may die, they mobilize funds from wherever source. They don't see value in preventive care. They don't see value in promotive care. For the reason that you outlined in the beginning, the health literacy in terms of understanding the elements of health promotion, prevention, and the behavioral elements of, even if you are literate, I mean, many of us are literate, but we are illiterate in terms of behavior. So what are the behavioral levers that can modify these things? So from financing perspectives, the family will have their own method of finance. But there is a illiteracy in terms of what options they have. They don't have the conceptual understanding of risk pooling. It is only at an insurance company level they talk of it. But at a population level, they don't have perception of what it means by risk pooling. Some of the experience of financing, for example, I am protected as an insurance. This happened during the COVID. I'm covered. I was careful. I was literate. But when I went to the hospital, because the insurance did not agree to covering a lot of other protective equipment and other things, the hospital started refusing, saying that our beds are full. So then people tend to lose confidence in the insurance mechanism. And also there is another element in terms of your personal thing, that as a medicine is something where it is a choice. You have to trust the doctor, you have to trust the institute. Just because you are empaneled, you don't go there. So that is again a unique issue in terms of financing. From the patient survey, I will tell you exactly what is the financing behavior of patients. We looked at health seeking behavior and what is their financing behavior. They have a facility. I mean, primary health center is there. There is a CSC. There is area hospital. Why they are not going there? It is free. Because they don't trust. It is a trust deficit. The simple thing is the doctor is supposed to be there for 2 hours. When we go there, he's not there. My day wage is gone. Can they take my sample in the 8 o'clock in the morning so that I don't lose the day wage? So this responsiveness of the system. So whichever system is responsive to the patient needs. When I say patient needs, when they need it, where they need it, how they need it. So they are willing to pay and they have to trust. I mean, these are some of the human elements which, I mean, in the modern medicine of economics, we are losing sight of. So, from like in the studies, when we looked at the Chinese and Southeast Asia, some of the innovative financing models, we have in India the cheat financing. You know, that is the best method of financing for health and education and marriage and everything. There's microfinancing, you don't have to mortgage anything, there is a trust. And that is exactly now modernly you are talking as mutual aid. That means all the people come together online and pool up the contribute every month. In a conventional private insurance, you have to contribute every year. You may not have that lump sum money to contribute. So the current financial technology enables you to actually pay the premium every month. And it can be online mutual collaboration. Because the whole talk about the missing middle is that the informal labor, you cannot get to the social insurance. But how do you pool the risk of the missing middle? So you open an online mutual aid. I mean, this is very and most convenient of covering the missing. Not cover, they could cover through a mutual. So China also has adopted that. Similarly, the government says I will cover only 5 lakhs. You know what happened during the COVID? It was average 20 lakhs, 30 lakhs bill. So that means then you need to have even if I'm a PMJ beneficiary, I need to have, like in the US now they call it Medicare Plus. I need to have a top up. I'm willing to pay for top up for additional 20 lakhs coverage. So there are a lot of, in fact, we released a report on that in terms of what are the innovative financing solutions for unprotected health needs from a family's perspective. So maybe I think that report can show more light based on the case studies, innovative financing methods that are coming up in different countries. Every country is facing the same problem. That whatever your 20% GDP expenditure, there are huge number of millions of people still uncovered. Some of the needs are not protected. So,
Excellent. So I think there is a lot of remaining questions that are still in my mind, and I'm sure in your mind as well. But I guess we have to take them later on going forward. And also there is another panel discussion that will be there in the evening. So we will try to take some of the questions during that time as well. And Jonathan will also participate there, so he can share some of his more economics oriented thoughts there. So for the time being, I guess it's good to end it here, and we have to go for lunch. And if there's some kind of sorry, yeah, please.
So I think before lunch, I think we from IHOPE we would like to felicitate the speakers and panelists with a small memento. So I'll just request Dr. Prashant to give a small token of appreciation to Dr. Krishna Reddy. Then I also request to felicitate Dr. Amit Dang. Thank you very much for coming. Then I request Dr. Raja to give a small token of memento to Neha Vivedi from IQVIA. Neha, can you please come there? And also, Kanchana, can you please come up? Yes, sir. Dr. Raja, can you please tell us? Kanchana. And just before, yeah, thank you very much again. It was a very good discussion. Can we have one photograph, please? Maybe all of us, probably here or outside or here. No, right here. Right here, maybe. Yeah. So may I request everyone to stand in front of accommodate. Yeah. See the session speaker. Yes, yes. Including you, sir. Yes, please. Because the session speakers join here.
On top of the stage here.
Yeah, there are three.
Up and down.
Up and down.
So please come.
Hi.
Please have next. Totamuti.